Good morning, everyone. Welcome to our Resident Research Day presentations. It is a pleasure, excuse me, for me to introduce our invited speaker for this Resident Research Day, Dr. Bradley. Dr. Kay Bradley is a professor in obstetrics and gynecology at the University of Iowa Carver College of Medicine, with secondary appointments as a professor in urology and epidemiology in their College of Public Health. She's division director of urogynecology and reconstructive pelvic surgery, as well as the fellowship program director in female pelvic medicine and reconstructive surgery. Dr. Bradley is recognized nationally and internationally as a clinical and epidemiologic researcher in female pelvic floor disorders and an academic leader in the FPRMS world. She completed her OB/GYN residency and FPRMS fellowship, as well as master's degree in clinical epidemiology at the University of Pennsylvania before joining Iowa's faculty in 2003. Dr. Bradley's research interests focus on diagnostic and outcome measures for urinary incontinence in women and on risk factors and symptoms associated with urinary incontinence and other pelvic floor disorders. Her past research was funded by the NIH and VA, has included developing and testing a new diagnostic questionnaire for female urinary incontinence and a nationwide longitudinal study of women veterans to better understand temporal associations between mental health disorders and overactive bladder urgency urinary incontinence. She currently co-leads Iowa researchers in an NIH-funded network studying women and men with lower urinary tract dysfunction to develop an innovative symptom-based instrument and to collect detailed longitudinal data to better understand phenotypic subgroups of patients. In addition to her positions at the University of Iowa, Dr. Bradley is currently gynecology editor-in-chief of the prestigious American Journal of Obstetrics and Gynecology, and she was elected in 2020 to a 4-year term on the executive board for the American Urogynecologic Society, currently serving as president-elect. As a personal note, as a residency program director, Dr. Bradley, I really appreciate you taking the time to come and speak with our residents, listen and enjoy some of the research they've done. So I thank you for your time. We've enjoyed a great relationship with our neighbors to the south at Iowa, and just another example of that. So thanks for being on today and sharing what you've learned and what you know with our residents and our faculty here.
Dr. Spencer, that was a really nice introduction. I am so pleased to join you this morning, both to present and also to participate in your Resident Research Day, which I always enjoy. And I know I enjoy our similar kind of events once a year. I was really looking forward to potentially being with you in person. I don't think I've gotten a chance to visit Madison for about 30 years, so I think it was time. And so I'm sad that it has to be virtual, but since I'm presenting virtually, I thought I would share within some of my slides. I have some pictures of Iowa City and the University of Iowa and our hospital complex. So I'm kind of sharing a little bit of Iowa City virtually with you. I'm going to talk about overactive bladder today, and it's a talk kind of divided into several little sections where some of them are talking a little bit about research that I've done related to overactive bladder, others about important kind of emerging topics in the field, and finally about research that I'm hoping that's kind of ongoing that I'm hoping is going to change the way we treat patients with overactive bladder. I'm trying to tie each of these little sections and each of the little sections when I can with some clinical recommendations, and so I hope this is useful and interesting to everyone. These are my disclosures. I don't have any relevant financial relationships related to this topic. And here are my learning objectives. So I'm going to talk about some what we call non-urologic clinical factors that may be related to overactive bladder, including lifestyle and behavioral factors, mental health, and history of trauma and other exposures and their relationship to overactive bladder. And again, I'm hoping that I'll tie this to how they may relate to clinical care and basically empower clinical providers to use some of these tidbits to better personalize their care of women with overactive bladder. So first, I'm just going to show a couple pictures before I get started with the real stuff. Here is a picture from 1930 of the University of Iowa Hospital, the original hospital. I'm using, I hope you can see my mouse, but this is this arrow. This is the original university hospital with these kind of crenellated towers. You can see Kinnick Stadium, even then, right, not that far from the university hospital, and even closer now, as you'll see in the next photos. So these actually are from the opposite perspective, and it just shows you the difference in 80 years. So here's the 1960s, and you can see again, here's those crenellated towers of the University of Iowa Hospital, the original hospital. Here's Kinnick Stadium. It looks like full even during a football game in 1960s. And then here's our current complex. And of course, all of these buildings, weren't there before. This is our, you can still see Kinnick Stadium right here. Here's our new University of Iowa Children's Hospital, just about 5 years old now. And just as a little note, my office is right there where the arrow is. That's where I'm sitting right now. So very close to the stadium. Things get very busy on game days here. Okay, so I'm gonna again talk about a couple different topics. I'm starting with just a basic review about overactive bladder to bring you all up to date on just an overview of how we diagnose patients and evaluate them and treat them. And then I'm going to focus a little bit on some research that I've been involved in related to overactive bladder and lifestyle factors and overactive bladder and mental health. I'm going to talk a little bit about antimuscarinic therapy and how this may negatively impact cognitive function and how this is changing our clinical care of patients. And then finally, talk about phenotyping in terms of current research that I'm involved in and how this might change the way we treat women with overactive bladder. So first, just the kind of review, and I can see the chat, and I know it's very difficult to make a virtual presentation at all interactive, but I don't have it. I would actually be happy to stop and answer questions at any time. But of course, we can do that at the end too. So overactive bladder is defined as urgency with or without urgency urinary incontinence, and this is usually accompanied by frequent voiding, whether during the daytime or at night. This is a symptom-based condition. So again, not all people with overactive bladder have urgency urinary incontinence, but you can see that urgency urinary incontinence is kind of a subgroup of patients with overactive bladder. We often kind of, in our not official language, might call that overactive bladder wet, meaning there's incontinence present as well, or overactive bladder dry. Overactive bladder is a very prevalent condition. So the numbers on this slide are from two large population-based studies of overactive bladder, one from the United States, one from Europe. They're a little older now. They're about 15 years old, although I think they're still some of the best prevalence studies that have been done. So we know that overactive bladder affects about 1 out of 6 women when you look at all ages, and about anywhere from a third of those patients to a half also have urinary incontinence associated with their overactive bladder symptoms or urgency urinary incontinence. The most important risk factors are age and body mass index. So we know that as ages increase, the prevalence increases significantly into our elderly patients. And it's a complex set of symptoms. Not only does overactive bladder include many urinary symptoms like urgency, frequency, incontinence, but there's other symptoms overlapping like stress incontinence and other types of urinary incontinence or voiding symptoms. This slide just is making the point that this is a condition that really has negative impacts on quality of life. This graph was from the American study, which was called the Noble study of about 5,000 American adults. And you can see this dark line shows the people with overactive bladder who had urgency incontinence as part of their symptoms. The dashed line above it, those without incontinence, and then controls. And in every domain, people with urgent incontinence as part of their overactive bladder had worse quality of life, than those without incontinence, and worse quality of life than controls who have better quality of life in all domains. The EPIC study, the European prevalence study, was more of a case control study, but also confirmed poorer overall health, more mental health problems, work problems like unemployment and poor work productivity, and sexual dysfunction in those who reported symptoms consistent with overactive bladder. And we know this is important in terms of economic impact and in terms of demographics. Women, as I mentioned, the prevalence goes up as age goes up. As you can see in the slide is actually graphing some of the prevalence results from the Noble study, the American study. As in the highest age groups, it's estimated that anywhere from 25 to 50% of our patients may have symptoms consistent with overactive bladder. And this is our most rapidly growing segment of the population, so very important care need probably in the coming years, and an important economic impact. I'm just going to shift now to talk briefly about diagnosis and treatments. The American Urological Association publishes a guideline on the diagnosis and treatment of overactive bladder. The kind of full guideline was published almost, I guess, 9 years ago now. It was updated in 2014 and then again in 2019. And you can see that it's a little bit complicated, but really it's not that complicated. So our evaluation of overactive bladder is an outpatient clinic evaluation. Our job is to exclude other important diagnoses or concerning findings. We need to do a thorough history, a physical exam, including a pelvic exam, and then a urinalysis for these patients to rule out hematuria or cystitis or other findings. Some patients should also have other testing like urine cultures, post-void residual volume testing to make sure people are emptying their bladder. And then voiding diaries and questionnaires can be helpful. We do not need to do more testing like urodynamics or cystoscopy or imaging in order to give our patients a clinical diagnosis of overactive bladder and begin non-invasive treatments. And because of that, because of the high prevalence of overactive bladder, we really hope that many primary care providers are evaluating women and men for these symptoms and offering initial treatment. Moving into the treatment recommendations, and again, this is from these guidelines, you can see that our mainstays of treatment for the great majority of patients with overactive bladder are behavioral treatments and pharmacological treatments, either one at a time, first line, second line, or even, combining them. And if patients don't respond to those treatments, then it is appropriate to kind of reassess them and make sure we think we have the right diagnosis, maybe do more testing in some patients. Potentially, if patients are being treated in a lower acuity setting and not responding, that would be an appropriate time for them to be referred to a specialist. In patients who have exhausted these kind of primary treatments, the current guidelines suggest then we can offer them additional options, and we call that refractory overactive bladder, although I think there is going to be growing evidence that some of these treatments are reasonable maybe earlier in the treatment algorithm. And so I look forward to future guidelines that may make these options available a little earlier to patients. Those treatments are intradetrusor Botox injections, peripheral tibial nerve stimulation, and sacral neuromodulation. So I think that what's important to understand about overactive bladder is that it is a heterogeneous condition. People have similar symptoms, although they can be complex, but may have very different look to them, and we call these phenotypes. So imagine one patient I might see for overactive bladder would be a young woman, nulliparous, with anxiety, who presents primarily with frequent voiding during the day, and maybe not with incontinence. Conversely, another patient, maybe 63, obese, a smoker with high caffeine and fluid intake. She's complaining of frequency, but also nocturia and frequent urgency-related incontinence. Another patient may be an older patient who's had a hysterectomy, maybe of normal weight, who has maybe closer to normal daytime frequency of voiding, but nocturia and has significant urgency incontinence more than once daily. That's really limiting her ability to participate in social activities. And then another final example, maybe a 50-year-old patient with obesity who also has other pelvic floor problems. She has anterior vaginal prolapse and stress incontinence, along with her urgency incontinence and urinary frequency. So you can imagine, while these patients have very similar symptoms, and while at this point we don't have a lot of evidence that helps us maybe personalize how we offer treatments, they seem different. And so I think there's a growing consensus that we really need the evidence to help individualize our care for these patients, whether that is through their risk factors, their different clinical histories, their different symptoms, or different functional testing, or even things like biomarkers or genetic testing, looking to the future, because we're not there yet. Okay, so I'm going to move on and talk about lifestyle factors, and just tiny interlude. This is the slide, of course, is the iconic Iowa wave. This started after the Children's Hospital, the first season when the Children's Hospital had opened. And it's now this kind of fun tradition that in between first and second quarters at Kinnick Stadium, everyone in the stadium turns around and waves at the children and their families who are in the hospital. They get to go when they can to the top floor of the hospital and watch the game from there. So kind of a very fun Iowa thing. Okay, so why talk about lifestyle behavioral factors? This may seem like low-hanging fruit, not that important. We know that these are first-line treatments for overactive bladder. Overactive bladder is a quality of life problem for patients, and we want to offer low-risk treatments when we can. But I think that I would argue that really trying to get patients to change behaviors can be potentially obtrusive to their lives. And it's very easy for me to tell people to change their behaviors, but I actually find it really difficult to change my own behaviors. It can be stressful and difficult for people and their families. So I feel like it's important that we actually know what evidence is supporting that there's efficacy in these recommendations. And it's hard to really spend a lot of time counseling or educating patients or arguing with them about changing behaviors if we're not really sure it makes a difference. So that's why I think that it's important to study these factors. I have been doing research with the Learn Research Network, and I'm going to kind of introduce the network later in my talk. But this project was done as part of Learn in our first cycle, and we were trying to initially come up with a list of all of these non-urologic factors, these kind of explanatory characteristics or related conditions or histories that we think may impact overactive bladder. And we came up with a lot of these, and we kind of categorize them. And as part of this, we felt this first box here, kind of lifestyle things that we do every day in terms of diet or fluid intake, other consumables, may be really important. These are often things that we counsel patients about, and we wanted to know how much evidence was there really out there that changing these things might make a difference in their overactive bladder. Are they really associated with overactive bladder? So we embarked on a systematic review to really explore the evidence. This is now 5 years ago. I think this was published in 2017, almost longer. And our research question focused on 5 lifestyle factors. We were looking at diet, fluid intake, caffeine, alcohol, and tobacco use. And we wanted to know if these factors individually, kind of separately, were associated with the prevalence and or severity of lower urinary tract symptoms in men and women. So it was a little broader than just overactive bladder, but we soon found that we found a lot of the literature focused on symptom or diagnosis groups, and we ended up dividing our kind of what we found in those groups. And so I'll mostly present the results today that we found related to overactive bladder and overactive bladder symptoms. We kind of followed normal or common methodologic steps for systematic reviews. We were unable to do a meta-analysis because we found that the data were largely observational and very heterogeneous. So we ended up including 111 unique articles. And you can see that the level of evidence was generally really low. So less than 10% of these articles were randomized trials, and 60% almost were level 4 or cross-sectional studies. So really not very high quality evidence. The next couple of slides just show our results. This first one is the slide summarizing our results on the literature for fluid intake and its relationship with lower urinary tract symptoms. We found 21 studies that we could include. And if you just look at this overactive bladder column here, we found 7 studies. Now, this evidence was actually a little better than other topics and sections because there were 3 randomized trials within this. And our bottom line findings were that fluid intake was associated with frequency and urgency in men and women. And these associations were bidirectional. So increasing fluid intake caused increased symptoms of frequency and urgency, and reducing fluid intake caused lessening symptoms of frequency and urgency. The associations with incontinence were not as clear. It was not really shown that this association was there. This next slide shows caffeine intake. Some of these studies overlap. They were the same studies. Again, we looked at multiple conditions encompassed among kind of lower urinary tract symptoms, but looking specifically at the OAB studies, there were 6, again, a couple of randomized trials. And our conclusion was that caffeine reduction seemed to be associated with small improvements in frequency and urgency in women. And maybe there was a weak association also between caffeine and urinary incontinence. The other 3 factors that we focused on are listed here because we really didn't find consistent or convincing evidence for associations. And these included diet, alcohol, and tobacco. So, looking at different types of diets, different dietary supplements, we really didn't find any consistent evidence between those and overactive bladder. And some effects of diet really seem to be occurring indirectly related to weight loss. Many of the studies were more related to weight loss. Alcohol also, surprisingly, maybe didn't have consistent associations or wasn't that well studied. And finally, tobacco didn't seem to have consistent associations, although we certainly know that tobacco use is associated with bladder cancer. There weren't consistent associations with lower urinary tract symptoms. Maybe a little bit of an association between tobacco and frequency in women, although most of those studies were pretty poor quality, and they were old. They're mostly from the 80s and early 90s. So our conclusions were, first, that there wasn't as much evidence as it seems we should have about lifestyle factors in overactive bladder, since these are our first-line treatment recommendations. Most of the evidence is observational. But there were suggestions that fluid intake and caffeine intake are associated with overactive bladder symptoms. And I think that is reassuring, as they tend to be at the top of our recommendations for patients. So, little clinical tidbit to tie up this section. What should we recommend? While I think there is evidence linking caffeine to symptoms, the actual treatment recommendations are not well studied. So this is kind of expert opinion, but I generally recommend that patients reduce their caffeine if they are caffeine drinkers, to try to get down to just 1 beverage daily. Usually I tell them to do that gradually if they're drinking a lot of coffee. And then I also, after doing this review and really looking at the studies on fluid intake, I do spend more time talking to my patients about how much fluid they are taking in, and often suggest that they reduce their overall fluid intake by 25%. Now, we don't want them to reduce to less than 1 liter of intake daily. And so it does help to spend some time talking to patients or doing a bladder diary before making this recommendation. And how do these 2 things kind of go into the rest of our behavioral modifications that are recommended for overactive bladder? So in addition to reducing fluid intake, we talk to patients about reducing nighttime fluids because of if they have nocturia or nighttime voiding symptoms. We often recommend eliminating other dietary irritants, not just caffeine, although again, the evidence is not quite as good, I would say, as for caffeine. So I often talk about carbonated beverages or alcohol, sometimes extending that to things like spicy or acidic foods. So again, we're pushing into areas where the evidence is not as good. We talk about different voiding schedules, weight loss, and managing constipation. And that's where these kind of lifestyle factors fit together in our recommendations for patients. Okay, so I'm going to go ahead and just discuss a little bit about overactive bladder and its associations in many patients with mental health problems, some of the research that I've done in a veterans population, and then again, how that might translate to clinical recommendations. So we know from a good literature, mostly epidemiologic, but also just description of our patients in clinical trials, that mental health conditions often co-occur with urinary incontinence and overactive bladder, things like depression, anxiety, post-traumatic stress disorder. And it seems that these associations are really specific to urgency urinary incontinence and overactive bladder, and not so much to stress incontinence. We know that when these occur together, this further reduces our patients' quality of life. There are theoretical mechanisms, kind of why these disorders may coexist. And this was kind of the impetus for me in getting into this, was to better understand these relationships with the idea that there may be overlapping mechanisms. First of all, certainly the functional and social impairment caused by bad urinary incontinence, severe symptoms, certainly could mediate the association and cause people to develop depression, for instance, or anxiety due to terrible symptoms, and kind of their response to them, things like limiting social engagement and interactions. But also it's possible that conditions like depression, anxiety, and urgency urinary incontinence may share a common pathophysiologic pathway. And some basic and translational research suggests maybe these pathways could involve the HPA axis or serotonergic systems. And I think that, of course, while this may be the case, there's probably multifactorial reasons for these associations. And when I was starting this research, my co-authors and I, co-investigators, kind of developed this conceptual diagram of all these different factors that may underlie the associations between psychological symptoms and these different urogenital or urinary symptoms, including the biologic mechanisms I mentioned, but also environmental factors, individual factors, and health risk behaviors, for example. And I was interested in the women veterans population. I was working with some researchers at our Iowa City VA hospital here. We knew that women veterans were a population that was increasing. This was when I was beginning this research, was when the Iraq and Afghanistan wars were ongoing. And so more and more women were involved in deployments and then were returning for care at the VA. We wanted to understand their physical and mental health problems post-deployment better. We knew they were at high risk for mental health conditions and previous traumatic exposures. And I felt that that likely meant they would be at high risk for some of these urogenital conditions like overactive bladder. And I was very interested in better understanding these conditions in this important population, and also being able to look at the temporal association of these conditions in this study. So the primary objective was to study the impact of depression, anxiety, and PTSD and a history of sexual assault on the natural history of overactive bladder. This was a one-year nationwide study of women who had recently deployed in Iraq or Afghanistan. We recruited these women from all over the nation by mail and telephone, and then screened them to rule out or exclude potential participants who we thought might have a neurologic reason or a urologic pathology that might lead to urinary symptoms. We also excluded recently pregnant women. And then we did a very detailed telephone interview, computer-assisted telephone interview, both when we enrolled them at baseline and 1 year later. So this was all administered through our VA here, but enrolled women all over the country. We used a lot of validated questionnaires to get information about their urinary and pelvic floor conditions, and their mental health conditions. We asked a lot about sexual assault, and they gave their consent for us to ask some very kind of embarrassing and probably often troubling questions about previous assault or traumatic exposures, and these other factors here. We were looking particularly at overactive bladder, defined as at least moderately bothersome urgency-related incontinence and or frequency, and then identified these different mental health diagnoses, including diagnostic validated questionnaires. And I'm just going to show you a little bit of data about their population. So we actually enrolled 1,700 women and had baseline data on that number, and then had 1,100 come back for their one-year interview. And so I'm presenting these details here along with the longitudinal results, the one-year results. This is a young cohort of women, average age 32, so that's very different than a lot of the other epidemiologic studies in urinary incontinence that have been done. Most were, or at least half were nulliparous. They were of normal weight, a very relatively diverse sample, both in terms of racial ethnic backgrounds and the region of country that they came from. Here's some of their service information. They had all just been deployed within a couple of years, and many of them had two, or actually you can see about 50% had been deployed more than once in the past, and most were from the regular military. You can see they had high rates of these different mental health conditions, 10 to 20% for depression, anxiety, PTSD, and 1 in 4 reported a prior sexual assault. These were kind of our primary results looking at the incidence of overactive bladder or new overactive bladder at 1 year in patients who didn't have those symptoms at baseline. And you can see that overactive bladder was much more common in people with baseline mental health problems and in those with prior sexual assault. And then when we did very careful and a complex propensity score adjusted analysis, we confirmed that anxiety in particular and a history of sexual assault were both associated with a risk for new overactive bladder. So impacting potentially the natural history of overactive bladder. We found that remission of overactive bladder symptoms was also linked to mental health, and that it was less likely in women who had depression. So this confirmed, our suspicion that the natural history of overactive bladder is impacted by mental health factors, that these were longitudinal associations. They were actually bidirectional and suggesting potentially common biologic mechanisms, and adding a little bit of evidence to the literature focused on now trying to figure out these mechanisms, as they may be, this may be a potential area for new therapeutic treatments. And I think that this opens the door to us coming up with ideas for how we should be treating patients with these comorbid conditions. Should we be focusing on treating mental health problems, or at least making sure they're being treated well? Screening for urinary symptoms in patients in, seeking mental health care? And should we be developing new behavioral cognitive therapies specifically for these women with comorbid mental health and urinary problems? And how might this impact our clinical care? This is still expert opinion. We have some pilot data about things like stress reduction, like yoga and mindfulness-based stress reduction, and in populations of women with urgency urinary incontinence. Very early randomized trials, for instance, but they're small. I think we need more of those data. I do think it makes sense to encourage patients to make sure their mental health is well cared for, and focus on stress reduction and behavioral therapies for overactive bladder when they seem to be tied to these mental health symptoms. All right, so just a couple more topics and we'll tie it up. So this is kind of an important thing I really wanted to mention, because it's really impacting, I think, our field and how we care for women with overactive bladder, and I'm sure men as well. It's not an area that I've done research in specifically, but it's definitely on many of our minds. So we know that overactive bladder increases with aging, as I mentioned, and some have listed or described overactive bladder and urgency urinary incontinence actually as an early marker of frailty in elderly patients. But we really have less research and high quality data for overactive bladder treatment outcomes in our oldest and kind of less healthy, frail elderly patients. Not surprisingly, this is the case for a lot of other conditions as well. There is some research that's been done in older adults. So there's some studies that suggested that our antimuscarinic medications are effective, but maybe older adults need higher doses. Older adults are more likely in at least one study to kind of request restarting medications after it's been stopped compared to younger patients. There's one nice and well done randomized trial testing fesoterodine, one of the newer antimuscarinics, for overactive bladder in a population of patients that were recruited specifically to be an older population with comorbid medical conditions. So they had to be, I think, over 60 or 65. And on average, most of them had 2 comorbid conditions. The average age was 75 in that trial. And they found that fesoterodine was effective for overactive bladder. And really the results are very similar to efficacy trials done in younger and healthier populations. So the antimuscarinic medications work in our older patients, but there's increasing evidence over the last 5 to 8 years, I'd say, that they may cause problems with cognitive dysfunction over the long term. And I'm just going to mention a couple of these studies. A prospective study in a large healthcare system found an increased risk for dementia and Alzheimer's disease. These were using diagnosis codes. So this was kind of a claims data study. And they found that these relationships were present in those health system members who had been exposed to the highest amounts of anticholinergic medications in general, not just overactive bladder, which is medications, which are one subgroup of anticholinergic type of medications. There was a longitudinal study that not only found an association between anticholinergic use and some mild cognitive impairment and or dementia, but also looked at some biological objective findings with functional MRI and other outcomes. They did see some increased neuroimaging markers of brain atrophy in those on anticholinergic medications. And then there's a very large case control study. This was one of a couple of the largest studies that's gotten the most interest, I'd say. This was done in the UK using their general practice data, again, kind of claims data study looking at prescriptions over many, many years and diagnosis codes for dementia and cognitive dysfunction. And they studied, over 300,000 people and found that any anticholinergic use over time was associated with an increased risk for cognitive impairment and dementia. They found a dose response relationship. This was a pretty robust association seen when they looked at it in many ways. They looked at multiple types of anticholinergic medications. They were able to do that because of the large size of the study, and overactive bladder medications were one of the types of medications that were associated with these adverse outcomes. There's a lot of discussion about whether these are true causal mechanisms, because again, this in particular, these are epidemiologic data. There are, we know when we treat patients that acutely anticholinergics can cause things like confusion or even delirium in some cases, but these seem to be longer term outcomes. And there's arguments that maybe some of this association is kind of confounding by indication. So in some cases, overactive bladder symptoms may be an early sign or manifestation of kind of impending dementia. And so a patient with those symptoms may be more likely to put on overactive bladder medications than another patient who doesn't have kind of pre-dementia. But that might not explain some of the associations found that even anticholinergic use 10 years or 20 years prior to a dementia diagnosis seems to increase the risk. So I think we don't know the final answer, but I think the evidence is growing that there is a relationship here, and this has certainly changed our care. There are some still arguing that, and I see this argument, that we need to do kind of a risk-benefit analysis for our patients, that many of these data are looking at a very high anticholinergic burden, so maybe it's safer in patients without that. And finally, there's really less data for the newer antimuscarinic medications, and there's a little bit of data suggesting they are safer than oxybutynin, which many of these studies was often including the older agents like oxybutynin, which certainly seems to have a higher risk for brain effects, and which we know crosses the blood-brain barrier potentially to a greater extent than some of the other antimuscarinics that we now have available. But we just don't know. We don't have a lot of data for those to prove that they're safe. And there is a little bit of prospective testing that suggests some cognitive safety in some studies, even in cognitively impaired adults. So I think the jury is still out on a final word, but this is definitely changing our care. And the guidelines are older and are still pretty non-specific, but I think newer guidelines will be coming out. And the American Urogyne Society in particular held a State of the Science conference in December, focusing just on this topic I was unable to go, unfortunately. I know Dr. Brown was there. And I think this is a really important area. There will be new things coming out to help clinicians guide their care, I would say. At this point, I think we are significantly trying to reduce use of these antimuscarinic medications in older adults. And again, there's really limited data to prove that, yes, some of these agents, some of these antimuscarinics may be safer than others. But in patients that you have a frank conversation with and who feel that the risk-benefit analysis favors treatment, which may very well be the case, and I have patients like that, it might be reasonable to use some of the agents that seem to be safer, like trospium in particular. And just the impact on my, and then of course we do have another class of medications now. We have the beta-3 agonists, which is the main one is mirabegron, and these don't have this risk. They are great medications. Unfortunately, they are extremely costly. For the great majority of my patients can't afford these medications, and insurance companies make them very highest tier, and often, they have very, very high copays, and they're just out of reach for most of my patients, I would say. So I think this is an area that we need more information on, and potentially help making these safer drugs more accessible to our patients. So what should we recommend? I think this is, in my practice, this just means that I have to talk to my patients a lot more and educate them about the risk benefit to using antimuscarinic medications. We need to maximize the use for other treatments. This really emphasizes the importance of more research on our behavioral things that don't have these risks, particularly in patients who have bothersome overactive bladder, but maybe not severe enough that they want to go on to more invasive treatments. And when we are treating, we need to be cognizant that we need to minimize risks. These are overactive, these are quality of life conditions. We don't want to harm our patients. Obviously, something like dementia is not a reversible condition, and we don't want to contribute to the risk for that, for sure. Okay. So just very briefly, my last little section here is about the idea of phenotyping and some new research that I'm doing along with the Learn Network that I think is exciting. So as I discussed earlier, urgency is a really heterogeneous or overactive bladder, with the kind of primary symptom being urgency, is a very heterogeneous group of patients. This is a condition defined by symptoms, and while symptoms may be somewhat similar, sometimes patients can look very different. So many of our treatments, particularly our behavioral and pharmacological treatment outcomes, are kind of moderately successful at best, and adherence is often poor, potentially because they're not highly successful or because they have side effects like our antimuscarinic medications. The Learn Network is a NIDDK funded research network trying to better understand these benign urologic conditions in men and women. Our first, the research in our kind of first cycle focused on more broadly lower urinary tract symptoms. And now this cycle, we're really focusing in on urgency and overactive bladder. And I love this picture just because this was the last time we had an in-person meeting pre-COVID. And now, 3 years later, we're really hoping that we just might have an in-person meeting in July. So we'll see if that happens, like all of our other meetings. So we think of phenotyping as identifying and explaining important subtypes of urgency patients by really characterizing patients well, including a wide range of potential factors, and going from clinical factors to exam findings to biological factors, and even these kind of related kind of comorbid conditions. These are just the 6 sites that are participating in Learn, along with a data coordinating center. So it is multi-center effort. And this is just an example of our current protocol, which is called the Urinary Urgency Phenotyping Protocol. It's a 1-year observational cohort study. we will be enrolling about 1,000 participants, both urgency patients and some control patients. We have several kind of sub protocols, which are getting even more detailed information in some of these areas. Some of the objectives of the main observational study and the primary objective just at the top here is to identify these clinically relevant, we hope, and distinct subgroups or phenotypes of patients with urinary urgency. And right behind that is to study and get a better idea for these non-urologic factors and whether they're associated with urgency subgroups and most importantly with treatment response. And I'm just going to go to the next slide. This just shows kind of the detailed data collection that we're doing. We're really trying to, we call it deep phenotyping, do a deep dive in terms of really well characterizing these patients who have urgency that's bothersome enough that they're seeking care. And we're very carefully monitoring their, while it's observational, so we're not, they are undergoing treatments of various kinds, and we're trying to carefully record those treatments and their treatment response over time. And this slide just shows kind of all these different things that we think may impact their condition or potentially their treatment response, maybe most importantly. So, you know, we hope that through these efforts, we will be able to stratify urgency patients into clinically meaningful subgroups, contributing to our personalized, more personalized management of overactive bladder with the goal, of course, of improving, bettering our outcomes. And these data will also potentially be able to be used to maybe design future clinical trials to really make sure that we're collecting the important information we need about subgroup analyses, or even focusing on kind of or targeting different clinical phenotypes in our treatment trials. Okay, so in conclusion, just going to sum up, and then I'd love to answer questions and really appreciate your attention this morning. So, you know, I feel that non-urologic factors play an important role in overactive bladder, and potentially more so than in the other conditions I treat. So these include things like lifestyle factors, and I discussed the evidence that we identified for fluid and caffeine. It includes these mental health comorbidities and potentially cognitive function. That is now becoming, you know, one phenotypic area. And actually we added a cognitive assessment to our cohort study after starting it because of the increasing importance that we think it is to better characterize cognitive function in our patients. We're focusing on phenotypes. This is kind of a research focus that's going on in other conditions as well, but we're really hopeful that this will contribute to evidence that's going to allow us to eventually target treatments better, maybe better or improve the outcomes our patients experience with our treatments, with the goal of kind of ending in an era where we can provide more personalized medicine for overactive bladder and improve our patients' quality of life. I think that is my last slide. I do want to acknowledge my co-investigators for the different projects. I presented some of their research from today, both at the VA and in Learn. And I would be, you know, happy to take any questions.
Dr. Bradley, thank you so much. I think that was such a wonderfully informative talk, particularly, you know, as someone who is not an FPMRS faculty, I think hit on a lot of things that we see throughout OBGYN, right? In many of our patients, you know, no matter where and what they're presenting to our department for care, I think we come across these issues. And it was a wonderful and thoughtful update, I think, particularly on lifestyle modifications, which we tend to, you know, kind of simply tell patients to try. And your point about really knowing that evidence, because it is, you know, it can be burdensome to patients to adopt some of those modifications, was really helpful. We've got a few minutes for questions. I do see one question in the chat if we want to start with that. So Laura Cooney says, the Learn study sounds like an incredible multi-center observational study. What was your experience working with so many other institutions to set it up, and any advice for other investigators who would love to do something similar?
Yeah, you know, it is a really fun experience to work with people across different institutions. I think it's a little humbling, because I've found that going into those settings, sometimes things that I assume are just common knowledge or common practice, you realize talking to other people that you have a lot of respect for and other, experts in the field are doing things totally differently at another place, that you realize things that you hold near and dear to your heart are just custom or practice in some cases. So I think that that's actually a great benefit for working with people, and that's what we get from going to our in-person meetings and networking with colleagues across the country, these things that we've lost during COVID. In terms of how to do that, I think that's difficult. We were lucky enough that the NIDDK was really interested in doing these kind of multi-center research networks, both in IC, so bladder pain syndrome. I get to participate. Carl Creeder is a urologist here who's the PI for our, we're also part of the MAP network. So I get to participate in that area as well as in Learn. So looking out potentially for just RFAs when they come out. I do know that there are some kind of ad hoc networks that have been quite successful in gynecologic surgery. For instance, like the Society for Gynecologic Surgeons, if you're interested in gynecologic surgery, is a great place for meeting other people who are interested in trying to do good research. And I know there was a group, for instance, that put together a little ad hoc multi-center group that did a bunch of studies that were things they could do without external funding, that have produced some good research publications and good evidence that we can use in practice. So I think it's hard to do, but there are potentially opportunities for that. I don't know if you guys have any other experience. I'd be happy to hear about your thoughts in terms of getting, multi-center kind of opportunities for research, whether externally funded or not. I think Dr. Brown also had a question in the chat. It's fun to see people I know, like Drs. Brown, Giles, and Heisler. Thank you for attending. So she said, I always wonder whether these patients develop overactive bladder symptoms earlier and thus get treated with more medications. Like dementia patients, yeah. I think that there is certainly, that probably accounts for some of the associations that we see, that confounding by indication. There was one other large study, which I actually didn't have in my slides, where they estimated that of this potential association, like 10% of the association, might be related to antimuscarinic use in terms of dementia risk. So not, I definitely think there is probably a relationship there, but it is going to be a complex one. And I do still offer some patients antimuscarinics. It's become a really difficult part of our practice because when you see an elderly patient with many comorbidities who's on many medications, it really limits the things we have to offer them potentially for their overactive bladder, that we can't use these medications that are within their reach, and that they can't afford often the ones that might help them.
I have a question, follow-up question on that. How did you get the word out to the rest of your faculty in family medicine and internal medicine about this? Because they're going to be prescribing a whole bunch of these medicines. Have you had any good luck with that?
It's a great point, Dobie. We want our primary care colleagues in particular to be treating overactive bladder. As I think I mentioned, the prevalence of this is high. There's good evidence that it is safe to begin a medication in people after just a brief evaluation, history exam, urinalysis. So we want them to be offering treatment. I have not done anything specifically related to that. I do get to occasionally do a teaching conference about urinary incontinence, for like our family medicine residents. And so I'm sure when I go back, it's usually like every 3 years. So when I go back to do that, I think that would be an important point to focus on. But I think that's a great point. How do we translate these? I think until it gets into our guidelines, it probably won't be that well recognized. I mean, I think it's certainly something that is very on the top of our geriatricians' minds. They certainly know this, but maybe not our, the family medicine people out in the trenches.
Great. Well, I think we have time for about one more question. If anyone else has any questions or comments. Just a reminder for anyone who did not see it in the chat, the code today is TUVCUB.
I just have one quick question.
Sure.
Luther Gaston. At least when I used to see patients myself, I see most of them with the residents now, but most of these patients, as they got older, had a component of incontinence with their overactive bladder symptoms. And what is the evidence? We've seen it in terms of stress, but in terms of pelvic floor therapy for urgency and frequency type of symptoms.
Thank you for that question. As I was I realized I forgot to say something that's probably important. When we talk about behavioral therapy for urgency urinary incontinence and overactive bladder, that encompasses pelvic floor therapy. So I'm so glad you answered that question, because I realized I forgot to say that as when I was kind of practicing, and then I still forgot. So there is great data, level 1 data, high quality data that shows that pelvic floor strengthening, pelvic floor rehabilitation, and then learning to use the pelvic floor muscles for urgency suppression is very effective for urgency incontinence and overactive bladder. And it's as effective as medications if you kind of compare trials side to side. Now, I think in real life, you have to find patients who are motivated to participate in behavioral therapy, like other behavioral therapies, they really have to buy in. They have to want to go to physical therapy. In patients so when I see a patient, I'm going to be checking whether I think they can do a coordinated pelvic floor contraction and understand how to do that. And then sometimes if that's the case, I can give them instructions verbally and give them printed information on, how to do a regimen at home and we call it the freeze and squeeze technique, how they learn to use their muscles to suppress urgency. If they're not very good at doing it on their own, then I would highly encourage them to work with a pelvic floor therapist or another type of behavioral therapist, person who does biofeedback, for instance. We most often work with our physical therapists. Here we have great women's health physical therapy, and I'm guessing you do as well, that can make a huge difference for patients. They also spend a lot of time on education, which just reinforces those behavioral modifications. So very important. Thank you.